So when we're thinking about regulation of cardiac output, regulation of cardiac activity, we need to think about the brain, which is a bit like a boxing glove. Here we've got the frontal lobes, the parietal lobes, the occipital lobes and the temporal lobes. And a lot of the autonomic activity is controlled by the brain stem at the front. And a lot of automatic learnt activity is controlled by the cerebellum at the back here. And of course the brain stem is continuous with the spinal cord below. And of particular interest when we're thinking about regulation is the brain stem part. So the brain stem is connected to the upper part of the brain here. Here we have the brain stem. The first part is the midbrain. The middle part is the pons with a bulge in it, and the lower part is the medulla oblongata. And the medulla oblongata is continuous with the spinal cord. So we have a midbrain, pons, medulla oblongata. And what we're interested in this talk is the cardiac centre. And the cardiac centre is located in the medulla oblongata. The American pronunciation for medulla, I believe, is medulla. But in England it's most definitely medulla. So that's the medulla oblongata here, and here we see the cardiac centre as part of the medulla oblongata. And the cardiac centre receives inputs and it receives outputs. So there's sensory information going in to the cardiac centre, and there is motor and other instruction type impulses going out. So it has inputs and it has outputs. So let's think first of all about the inputs. What is putting information into the cardiac centre in order to accurately regulate cardiac output? Because to know what outputs to generate, the cardiac centre must know what is going on in the body, so it can give an appropriate output to maintain the correct amount of cardiac activity, to maintain the correct homeostasis, mediated via the circulatory system in all systems of the body. So here we have the cardiac centre, which also controls other aspects of the circulatory system, the cardiovascular system, in red here, in the medulla oblongata. But it needs to receive inputs. And basically there's two groups of inputs that it receives. There's inputs from above, from the cerebrum, from the upper parts of the brain. So it's receiving inputs from up here. So inputs from up here are going to go down towards, on this diagram that would be the cardiovascular centre there in the medulla oblongata. It's receiving inputs from above, from the upper part of the brain, from the cerebral cortex. Now the cerebral cortex is aware of when we are about to do something, when we're about to do something energetic or something exciting or something that's going to require increased cardiac output. So there's a cerebral cortex can anticipate. So there's anticipatory inputs from the cerebral cortex going to the cardiovascular centre. And a lot of this is mediated via the limbic areas of the brain. Now the limbic areas of the brain are what give us emotion. So our excitement comes from limbic areas of the brain, and our fear comes from limbic areas of the brain. So we know if we're about to have a run or run away from a predator or do something that generates excitement, that's detected by the limbic areas of the brain. And the emotion generated is going to go to the cardiovascular centre. And you can relate to this from your own experience. When you're anxious or when you're excited, you're aware of an increased cardiac activity. You might even feel your heart beating in your chest because of the increased cardiac output. So from the cortex down the way to the cardiovascular centre. But there's also information comes from the periphery, from further down. So there's peripheral sensory information going up to the cardiac centre. And this can come from proprioceptors, chemoreceptors and baroreceptors. Now it's the proprioceptors that detect movement in the muscles and the joints. So when there's movement in the muscles and the joints that is consistent with exercise, so when there's movement in the muscles when you're running, that's detected in your leg muscles, in your knee joints, in your hip joints, in your ankle joints, that's going to send this proprioceptic information up towards the cardiovascular centre. So this is coming from the peripheral sensory information coming from the body, as opposed to this one at the top here, which was central information. And the proprioceptors will say, well, we're going for a run now, we're going to need some more energy. And this response is quite fast. So as soon as you start running, the proprioceptors are going to send information to the cardiac centre, and the cardiac centre is going to generate outputs which are going to increase cardiac activity. So what we actually find is that the heart rate increases before the amount of oxygen decreases and the amount of carbon dioxide increases. It's another anticipatory effect really, but it's a peripheral anticipatory effect rather than a central anticipatory effect. Now the chemoreceptors largely detect the amount of oxygen in the blood. So when the amount of oxygen in the blood drops, that's detected by the chemoreceptors. And if there's a lack of oxygen in the blood, we need a cardiovascular compensation for that, and the heart has to beat quicker. Because if we're going to get more oxygen to the tissues, we've got to get more blood pumping around the lungs as well to pick up more oxygen. So again, oxygen lack detected by the chemoreceptors is going to stimulate the cardiac centre in a positive way. And baroreceptors are the pressure detectors. And they're also going to send information to the cardiovascular centre. And we're going to look at these in more detail when we consider homeostasis of blood pressure. So we see these inputs into the cardiovascular centre. And the cardiovascular centre is brilliantly computing all this in order to regulate appropriate cardiac output. And there's basically going to be two forms of output from the cardiac centre. There's going to be activity of the sympathetic nervous system and activity of the parasympathetic nervous system. The sympathetic nervous system increases heart rate for fight or flight. The parasympathetic nervous system is going to reduce cardiac activity. Remember, it's the rest and digest nervous system. Both branches, of course, of the autonomic nervous system. So how is cardiac output going to be regulated by the sympathetic and parasympathetic stimulation? Well, let's think first about the effects of the sympathetic nervous system. So remember, this is all coming out from the cardiac centre. These effects on the sympathetic nervous system. Now the output is actually going to go down the spinal cord. It's going to go down the spinal nerves, because remember, the sympathetic nervous system is sometimes called the thoracolumbar nervous system. So the nerves are going to come out at the level of the thoracic nerve roots. Particularly T1 to T5 are going to be involved, as these are going to go to the heart. So it goes down the spinal cord. This information is going to go, output information, down the spinal cord to the down the anterior nerve roots, exiting at T1 to T5 to stimulate the heart. And actually the nerves, they don't go directly to the heart. Both the sympathetic and the parasympathetic nerves go via the cardiac plexus, which also processes information and is just below the aortic arch. So what actually happens here? Well, the sympathetic stimulation is going to innervate what we call these cardiac accelerator nerves. So there's going to be activity of cardiac accelerator nerves. And these cardiac accelerator nerves are going to have an influence on the sinoatrial node, the atrioventricular node, and indeed directly on the myocardium itself. They're going to influence all of these tissues. So when the cardiac accelerator nerve stimulate the sinoatrial node, that's going to increase the rate of depolarization of the sinoatrial node. So remember, the sinoatrial node will carry on depolarizing itself quite happily. And actually the intrinsic rate of this is 90 to 100 beats per minute. But cardiac accelerator nerves can make it depolarize more quickly than that, increasing the heart rate. But the cardiac accelerator sympathetic nerves are also going to affect the AV node, the atrioventricular node. Now you might remember that normally the atrioventricular node slows down the rate of transmission. Well, stimulation by the cardiac accelerator node is going to increase the rate of transmission. So the impulses are going to be generated more rapidly in the sinoatrial node and transmitted to the ventricles from the atrium more rapidly via the atrioventricular node. And the cardiac accelerator nerves are also going to directly stimulate the myocardium. And actually, I haven't put it here, but the cardiac accelerator nerves will also work on the coronary arteries. Now, the coronary arteries, you remember, are the arteries that supply the myocardium with blood. So the cardiac accelerator nerves anticipate the increased workload generated by these physiological effects, and they dilate the coronary arteries, meaning more blood goes through the coronary arteries to supply the myocardium with more oxygen, more nutrients, and to wash away more carbon dioxide. And indeed, the cardiac accelerator nerves, as well as dilating the coronary arteries, will also dilate the coronary veins. So more blood is drained more quickly from the myocardium as well. Now, these cardiac accelerator nerves are also going to release noradrenaline. Now, norepinephrine and noradrenaline are exactly the same molecule. They're exactly the same thing. So when you see norepinephrine or noradrenaline, it's exactly the same thing. Don't worry about it. So the sympathetic nerve endings are going to release noradrenaline. And these are going to stimulate what we call beta-1 adrenergic receptors on the cardiac muscle fibers. So on the cardiac muscle fibers, there's receptor sites, and the noradrenaline fits into these receptor sites. And when it fits into the receptor sites, it stimulates them. And the receptor sites are called beta-1 receptors, and they're located on the cardiac muscle fibers. That's this bit here. It's going to increase the contractility of the muscle fibers in the myocardium. And you've probably heard of drugs called beta blockers, because these both the beta-1 receptors. And drugs called beta blockers will block these beta-1 receptors, thereby blocking the sympathetic effect of the noradrenaline on the heart. So you might have heard of atenolol. That was probably one of the first ones. The one we use most commonly at work at the moment is bisoprolol. That's a beta-1 antagonist. It inhibits the activity of the noradrenaline. You can always tell beta blockers, they end in a lol. And they're inhibiting this activity. So a heart that's beta blocked will be unable to sympathetically respond. So these people can't exercise properly. That's why they get tired quickly if someone's on beta blockers. So these sympathetic nerves are working because they release this noradrenaline that stimulates the sinoatrial node, the atrioventricular node, and the myocardium. And we see there's basically two effects here. We're going to speed up the rate of spontaneous depolarization. So it's going to increase the rate of depolarization of the sinoatrial node. That's going to make the heart beat quicker. And when the heart beats quicker, that's called a chronotropic effect. So chronos is Greek for time. So that's going to increase the heart rate. It's a positive chronotrope. And we also note that it's going to increase cardiac contractility. So as well as beating more quickly, the heart muscle is going to beat more forcefully. It's a more vigorous contraction to increase cardiac output. And when we increase the rate of the heart, that's called a chronotropic effect. And when we increase the strength of cardiac contraction, that's called an inotropic effect. So it's going to be chronotropic and inotropic. So we're going to increase heart rate and we're going to increase stroke volume. And that's good, of course, because cardiac output equals heart rate multiplied by stroke volume. Now, there's quite an important point here to mention when we're considering children. Because children can increase their heart rate, they can have a chronotropic effect, but their hearts are small, so they're not very good at generating an inotropic effect. So remember, in your cardiac output, as we've seen, your cardiac output is equal to heart rate multiplied by stroke volume. So that's fine. So if your heart rate drops, you can compensate by increasing your stroke volume. So this is the chronotropic effect, this is the inotropic effect. But children are very bad at increasing their stroke volume. They don't have a significant inotropic effect. This is why when you see toddlers getting out of the car, they'll run off to the playground or they'll run off into the woods, and mum and dad will walk behind them. But very often after a few minutes they're tired out and dad has to carry them back. That's because they don't have this reserve that dad has. They don't have this increased inotropic ability to increase cardiac output by increasing the stroke volume. That's why slow heart rates are so significant in children. So if the heart rate in a child drops and they can't compensate by increasing their stroke volume, so a relative bradycardia for the age of the child is automatically going to reduce cardiac output. That's why slow heart rates are such an important clinical consideration when we're considering children. The increase in cardiac contractility actually comes by an effect on the cell membranes of the individual cardiac myocytes. These effects will enhance the entry of calcium into the cell. There'll be more calcium ions going into the myocytes, and that's what increases the strength of each individual cardiac contraction. So that's a summary of the sympathetic effects of the output from the cardiovascular centre. So that was the inputs on that side, and we've considered when these inputs are suggesting that we need increased cardiac activity. That's going to be this sympathetic effects, these sympathetic effects. But then when we want reduced cardiac activity, we don't want sympathetic effects, we want parasympathetic effects in this circumstance. We want activity of the parasympathetic nervous system. Now, the parasympathetic nervous system is largely mediated, at least as far as the heart is concerned, via the vagus nerves, the right and the left vagus nerves. And the vagus nerve is the 10th cranial nerve. It's vagus, it comes from the Latin for vagrant because it wanders around the body. It doesn't, it goes to very precise places, but that's where the name comes from. It's the wandering nerve. Because the parasympathetic outflow, you might remember, is called the craniosacral outflow. Craniosacral. So the parasympathetic nerves communicate between the brain and the body via the cranial nerves and via the sacral nerves. And the parasympathetic nerves are the 3rd cranial nerve, that's the oculomotor, the 7th cranial nerve, that's the facial, the 9th cranial nerve, that's the glossopharyngeal, and of course the 10th cranial nerve. the vagus nerve. And after the vagus nerve has gone down to the heart, it actually goes on to the gastrointestinal tract and innervates a lot of the gastrointestinal tract, up until 2/3 of the way along the colon, in fact. So again, here we're thinking about how this, when there's parasympathetic outflow, how this is going to work. Well, it goes via the vagus nerve, as we've said. And the vagus nerve, again, going via this cardiac plexus, but branches from the vagus nerve via the cardiac plexus, are eventually going to get to the sinoatrial node, the atrioventricular node, and the atrial myocardium. Now, what effects are the vagus nerve going to have on these three areas of tissue? Well, the vagus nerve is going to slow the rate of depolarization of the sinoatrial node. Now, as we've said, the sinoatrial node, left to its own devices, will depolarize, generating a new action potential 90 to 100 times per minute. So in you at the moment, if you're at rest, if your heart rate is less than about 90 beats per minute, that's because the vagus nerve is inhibiting it somewhat, slowing the rate of depolarization down. So the vagus nerve, the parasympathetic supply, is going to slow the rate of depolarization in the sinoatrial node. And it's also going to slow the rate of transmission through the atrioventricular node. That's good because it leaves plenty of time for the blood to get from the atria to the ventricle prior to the onset of ventricular systole, the contraction of the ventricular myocardium. And the vagus nerve doesn't really affect the ventricular myocardium very much, but it does have fibres that go into the atrial myocardium, and it's going to reduce the contractility of the atrial myocardium. So slowing down the rate of transmission, reducing the activity of the atrial myocardium. These are all effects of the vagus nerve as a branch of the parasympathetic nervous system. And as well as that, stimulation of the vagus nerve is going to constrict, it's going to vasoconstrict the coronary arteries. Because if there's less activity going on in the heart here, then we need less blood going to the myocardium. So the vagus nerve is going to constrict the arteries so that the blood flow to the myocardium is matching the metabolic demand. In this case, matching the lowered metabolic demand. The vagus nerve works by releasing acetylcholine. That's the chemical transmitter that basically the end fibre of the parasympathetic nervous system uses consistently. So parasympathetic stimulation of the sinoatrial node is going to slow it down. So the vagus nerve, the vagus nerve endings are going to release the acetylcholine. When the acetylcholine arrives at the sinoatrial node knows it's time to slow its rate of depolarization, and will do so with the equivalent effects on these other tissues. So what this is going to do is going to slow the rate of spontaneous depolarization. It's a negative chronotrope. It has the opposite effect. It slows the heart rate down, thereby reducing cardiac output. So we see that regulation of cardiac output is controlled by this cardiovascular centre in the medulla oblongata of the brainstem. It has inputs from the brain above and from the peripheral nervous system below, and it regulates cardiac output by outflow here, differential outflow of the sympathetic nervous system and of the parasympathetic nervous system. And there's an ongoing dynamic here, there's a balance. So when we need increased activity in the body, there's going to be sympathetic outflow. When we want decreased activity, there's going to be parasympathetic outflow. And these are constantly being kept in balance to maintain the homeostasis of cardiac output. which is going to maintain the homeostasis of all the cells and tissues in the body. Now, as well as stimulating the heart directly, sympathetic fibres also go to the adrenal medulla, giving rise to hormonal effects. So there's hormonal effects mediated via sympathetic stimulation of the adrenal medulla. So the adrenal medulla, of course, is the inside part of the adrenal gland. And this is going to release adrenaline and noradrenaline. Mostly, in fact, adrenaline. Or to put it another way, epinephrine and norepinephrine. And this is going to stimulate the cardiac muscle fibres, really in much the same way that the neurotransmitters released by the cardiac accelerator nerves did. Remember, they released noradrenaline and noradrenaline, which is norepinephrine, that stimulated the beta-1 receptors. So this is much the same, it's just that it's an endocrine effect because these hormones are released into the blood and circulate in the blood. But they're fairly short acting as well. The half-life of adrenaline is actually only 2 to 3 minutes. So it's a fairly short-term effect. So what you could say is that the sympathetic direct stimulation is altering heart rate on a second-by-second basis, whereas the hormonal effects are operating over a few minutes at a time. And of course, when the adrenaline and noradrenaline stimulate the cardiac muscle, that's going to increase rate and contractility. More slowly acting are the thyroid hormone. So thyroid hormone will also have a chronotropic and an inotropic effect, or that will work more slowly. The other main hormonal effect we're going to look at is the renin, angiotensin, aldosterone system, which is significantly longer acting. So really the effects we've looked at here, the sympathetic and the parasympathetic outflow, are second by second moderation of cardiac activity. This is minute by minute. And the renin, angiotensin, aldosterone system is hour by hour and day by day.